One of the things that I think people tend to forget is, here in the States, we talk about making eye contact, right? That's respectful. If you make eye contact, that means you have my attention, I have yours, right? And you immediately draw that connection. But when you meet an Asian patient, that may not always be the case, right? Depends on maybe how many generations in they are to the States. You talk to them, and then they're kind of looking down, looking around the room, and you kind of look at them like, hello, are you there? Are you paying attention? They're not being disrespectful. That's just culturally, you just don't make that eye contact.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of First Case, we are speaking with Charlie Lin. Charlie is a nurse practitioner and first assist at Stanford Children's Pediatric Otolaryngology, and he is a Taiwanese-American nurse who is passionate about helping others understand the Asian population and how we can culturally, competently care for Asian patients. And Chris, there's a lot for us to learn today, and I know that I have plenty of ways that I can learn more and understand more to provide better care. And I'm looking forward to how Charlie's going to open our eyes to some differences and some things that we just might not have thought of before.
Absolutely. This entire season is about learning who our patients are. And this particular, cultural background and population is growing in all parts of the United States. So I can't wait to learn from Charlie, who I'm just getting to meet and who I've heard so much about. So let's get started.
Absolutely. Don't go anywhere. We'll be right back with Charlie Lin.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Charlie Lin, nurse practitioner, first assist at Stanford Children's Pediatric Otolaryngology. And first, I'm proud that I said that correctly, but I'm also really glad to have you with us today, Charlie. So thanks so much for joining us.
Thank you so much for having me. It's such an opportunity and privilege to be part of First Case.
I know. I can't believe that when I asked you to be on the show that you hadn't been a guest already. And I'm like, how have we missed that? I don't know, but we are making up for it today. And Charlie, you and I think we've known each other for 3 or 4 years at this point. And the biggest way that we got connected was actually through AORN and through LinkedIn connections. And just I think a big plug here for the benefit of your professional organizations and getting to know the people in your field, because I don't think I would have ever met you, Charlie, otherwise if it hadn't been for AORN. And we're on different sides of the country. And yet, it's really cool to be connected with other nurses. And so shameless plug there for your professional organization, whichever one it may be, but get involved and get to know people, and you can meet cool people like Charlie. So Charlie, why don't you just go ahead and tell everybody a little bit about who you are?
And I think to exactly your point, Melanie, is that, at some point we could have crossed because both of us have connections in Dallas, Texas.
Yes, we do. Absolutely.
We both work there. Mm-hmm. And it's just very interesting that, the perioperative community is so big and you can easily cross paths and you just never know it. But what's interesting is that I never planned to be a periop nurse when I went through nursing school, because when I went in planning to be a NICU nurse because I love babies. And when I graduated out, I was top of my class in labor and delivery, obstetrics, and I was like, I'm going to be an obstetric nurse. It's going to be so great. But in my last semester, my professors placed me for practicum in the ER, and I was like, I'm a hands-on person. I'm kinesthetic. Yeah. This is where I need to be.
I get that.
So long story short is I didn't get into nursing school my first time around. They said my grades were too low, and I ended up going to Canyon, Texas, of all places. to get my bachelor's in nursing. So I graduated from West Texas A&M University in Canyon and came back to Dallas and got into the Baylor residency for trauma ED. And I started off my career at Baylor Irving, which is where I started my entire nursing pathway.
I started in the OR at Baylor as well, but different campus. That is crazy. Okay, keep going. Sorry.
It's so crazy. But eventually made a transition. And I think I'll kind of hint on it in a little bit, but I made a transition from Baylor to an ambulatory surgery center that's Baylor owned, physician owned, where I worked pre-op PACU, and then got literally dropped into the operating room without Periop 101, without knowing anything in the OR.
Hey, that's my experience too. That's funny.
And was just told, just open stuff for the surgeon. And I was like, okay. And that was my introduction to the OR, where I was like, oh, that's not what we do. Very quickly we realized like that was not how it goes. Yeah. Basically, in the OR, I met some great surgeons, worked with some great staff. And eventually, the anesthesiologist and the surgeons I worked with decided, they were like, hey, you're kind of smart. You should probably go become a CRNA or become an NP. And got my family nurse practitioner also back at West Texas A&M University. So I was a double buffalo. And so I got my family nurse practitioner there. And then a year and a half after I graduated, took my first job at University of Connecticut, John Dempsey Hospital in Farmington, Connecticut, as an otolaryngology head and neck surgery nurse practitioner, the first they'd ever had. Almost 2 years there, transitioned to Stanford Medicine, where I'm at now, where I work with children specifically in all sorts of different congenital diseases and different levels of acuity. I take care of kids in the hospital, first assist in the OR, and I'm in clinic.
Well, and also, I'm going to jump right in here because before we actually get into the rest of our conversation today, all of your work in otolaryngology and with working with kids, you also do a lot of mission work. And I can't go through this conversation without letting you talk a little bit about that first, because what you do is really cool.
And that's what's really interesting, is because this is why I didn't find Periop, which I continue to believe firmly that Periop found me. The OR found me. So I went to go do medical interpretation on live news for a plastic surgeon in Dallas, Texas at Medical City. Never met the guy. He shows up a little bit late. He's got an international patient from China and who comes, and they want to do a live news story on it, but they couldn't find an interpreter on a Sunday morning. And I was like, I'm a little ER nurse, kind of like a year in practice. I don't really know anything about plastic craniofacial surgery, but I'm available, so I showed up. But did the whole hour interview on live news, and at the end of it, introduced myself to the surgeon, after he introduced himself to me. And then he was like, oh, you're a nurse? You should come on a mission with us. I'm the founder of this organization. I was like, okay. Went on this mission to Haiti back in 2013, I believe, 2012 or 2013. Came back and was like, these patients actually thank you? Like,
they're appreciative.
I want to go work in the OR.
Yeah.
And that's when I came back, I was like, maybe I want to be an OR nurse. And so came back, got that job in the ambulatory surgery center, but then was still moonlighting as a trauma nurse in the evenings. But that's where my career in Periop grew. And since then, I have done over 40 trips to different countries all over the world, providing, surgical care, either as a circulator, as a first assist, as a charge nurse, as a nurse practitioner, doing pre and post-op clinics. So it's been really exciting, amazing journey.
This is crazy because I just met Charlie 10 minutes ago.
Yeah.
And I love the fact, I'm from Dallas, Texas. I did my clinical rotations at Baylor. I worked at a Baylor ambulatory. I did Baylor L&D. I was in Baylor's burn unit. Periop found me. You're Medical City. I was like, yeah, I've been there. This is such a small world. I'm so excited to.
So crazy.
Yeah, Perry, OR slapped me in the face and found me. So
I ran to the OR out of desperation. So it's funny the things that brought us to the operating room, and yet here we are.
Serendipitous almost, right?
All professionals. You're in Tennessee, Chris. I'm in Alabama. Charlie, you're in California, and yet we all have this same. We share something very much in common, and
the great state of Texas.
Exactly.
Great state of Texas.
Go figure.
And to this day, when people ask me, I still say that I'm a Baylor nurse.
Oh, yeah.
I don't care what people say. I am a Baylor bred and trained nurse. That is how I know how to nurse.
Well, and
there is the Baylor way.
I learned a lot of lessons about the OR from Baylor. Yeah. I'm not going to say if that's necessarily good or bad, but I did learn a lot of lessons and I took a lot away from it. Although it would be unfortunate of me to not give credit to UAB in Birmingham as well. Academic Medical Center, I learned a ton there as well. But yeah, we all have our roots at Baylor, and that is incredible to me. So as we think about this weird connection that we all have and how big the perioperative community is, but yet it can get really small really quickly as we realize how we're all connected. This season, we are talking about who those patients are on our table. And every patient comes in a different background, a different culture, a different ethnicity, a different religion, different social beliefs, all these different things. And as their care providers, we have to focus on them. And it's about them. It's not about me. But how do I educate myself so that I can fully take care of the patient in front of me and take care of them in a way where they feel safe, they feel heard, they feel valued, and they feel like they aren't missing out because I am dismissing them or ignoring them. And when I thought about this, and Chris and I had brainstormed a lot about this season, and then I go LinkedIn, gotta love LinkedIn. Please, if you don't have a LinkedIn account, please make a LinkedIn page and connect with us. But as I'm thinking about this season, Charlie posts on LinkedIn about speaking at the AORN Expo on the culturally appropriate care for Asian patients. And I'm like, bingo, yes, we need to talk about that. That is exactly what fits this season. And while we're recording this, you haven't gotten to speak yet at Expo. But when this airs, you will have already spoken, and I'm super excited to get to hear your presentation there as well. But it's going to be interesting to get to talk to you a little bit about those same topics and to learn about another population that we don't necessarily understand if we don't come from that culture. So, introduce this for us, please.
Yeah. So, kind of the premise for it is because, we talk about equity inclusion. We talk about being able to take care of patients. Our patients are not getting any simpler, any easier to take care of in the clinical setting. They're only getting more complex. And we've got more complicated disease processes. Our diagnostic patterns are a lot better. We have a lot more standards and guidelines to be able to better figure out who has what diseases, what conditions, and how do we best treat them with our evidence-based practices. But what hasn't changed is that our patients are still very diverse. They come from very different settings, and we still have a lot of very international patients within our workplaces. And we really can't forget that. As nurses, even as clinical personnel, outside the nursing profession, we have people that say that we need to have more education. But what does that education translate to if it actually doesn't become part of our day-to-day practice? And so that becomes a really big challenge when we talk about encouraging culturally competent care. We have a lot of patient populations like the Hispanic population whose primary language is Spanish, right? And so you can say care of the Spanish-speaking patient or care of the Hispanic patient, but they all still tend to speak Spanish, whether or not there's little minute dialect changes. I know in my workplace in California, I sometimes will see patients that have marked on their charts Mixteco Bajo or Triqui Bajo. And I know immediately that a language interpreter is not going to be appropriate. We need to contact the person who's local in their community that actually also speaks English as well to help with the translation, because Spanish doesn't always work that way, directly from a comprehension standpoint. So when it comes to Asian patients, though, we use a big umbrella to capture the Asian patient. But the problem is the Asian subset has such a large array and variety of patients. Because when we think of Asian patient, just think of Asia. There's so many countries there. And within those countries, there's different ethnic groups, different regional ethnic languages, a lot of them where they don't communicate. So how do we even start to begin to have that discussion on how do you actually take care of them and provide that culturally appropriate care for them, whether it's language, preoperative care, postoperative care, their cultural biases. We need to be aware of those things.
Yeah. And we need you to help us. So let's unpack that list you just gave us, right? I mean, what are cultural biases that we should be aware of? What are assumptions that we might make when we see someone who appears to be Asian that would be a wrong assumption or would be rude or offensive? Those are the things that we want to understand. And I mean, help us, please.
Yeah. Well, there's that first impression that you make, especially like Melanie has talked about it a lot of times when you're the circulator and you have those few minutes in pre-op to be able to establish this sense of trust with that patient prior to bringing them back to the operating room. You don't want to do anything that's going to increase the fear. You want to try to decrease it and calm them and reassure them you're going to take good care of them. And so, making sure you're approaching it appropriately is important.
Absolutely. Like one of the things that I think people tend to forget is, here in the States, we talk about making eye contact, right? That's respectful. If you make eye contact, that means you have my attention. I have yours, right? And you immediately draw that connection. But when you meet an Asian patient, that may not always be the case, right? Depends on maybe how many generations in they are to the States. You talk to them and then they're kind of looking down, looking around the room, and you kind of look at them like, hello, are you there? Are you paying attention? They're not being disrespectful. That's just culturally, you just don't make that eye contact. Because a lot of times it's like you're in trouble.
So they associate eye contact with punishment. Yeah.
Yeah, it could have a negative connotation to it. And it doesn't mean that you're not paying attention. It just is a sign of respect, right? And so if you're talking to the patient, they're kind of looking around the room or looking down, they might be nervous. That's very possible. They could also just be exercising what's normal to their culture, right? And other situations, you have to look at how the family unit is viewed. Here in the States, we tell patients, you have all the authority, all the rights to make your clinical decisions as far as your care, your surgical care, your postoperative care. You have the authority, you have the right. But for some Asian cultures, that's not the case because it's a family-driven decision. And so even if you keep talking to the patient, but the family won't stop talking, it doesn't necessarily mean that the patient is not participating. It's because culturally, it's a family-driven decision. It's a family-driven ideal as far as how is that care delivered and what's their decisions.
In that Asian culture, is it more age driven, like the eldest member of the family has more authority, or is it more gender driven? Like in some cultures, men have more authority than females. Like, is there a difference?
It's both, honestly. If you have a family where the oldest is a female, is a girl, right? And then the second child is the male. The second child, the male, may still have the decision-making authority, even though the male is not the senior in the family, is not the oldest sibling. Now, a lot of that has changed over time where things are more collaborative, where there's less of the gender-based decision-making, but some families may still follow that tradition. And so it's really important, at least if there's a key decision point that needs to be made regarding the perioperative care or the clinical care of the patient, is to ask the patient and the family, how do you like to make decisions? How do you make decisions in your family? Right? And so you understand that when you need to tell them about pain medications, postoperative care, you engage the family in addition to the patient. You engage the correct person to make sure that everyone's on board because, of course, compliance only improves postoperative outcomes.
So in that, by engaging the family and not just speaking to the patient, instead of feeling like you're bypassing the patient and talking to the family instead, it's not that you're violating HIPAA and sharing information you're not supposed to. It is, if that is correct in their culture, then that is something that actually is more inclusive and more making sure that the patient, like you said, we're going to have more compliance because we are being inclusive of the whole family and not just assuming we can only give this information to the patient, right?
Absolutely. Because that's one of those questions we should ask the patient, right? When we see the patient in pre-op, if you're the circulator, is, hi, I'm so-and-so, I'm your circulating nurse, I'm your perioperative nurse today, I'm going to take great care of you. Who is here with you today? And then as you get to know that have that interaction, you develop that bond that Chris was talking about, right? It's that 5-second best friend is what I like to call it.
Oh, that's a good way to put it. Yeah.
And as you develop that relationship, as you engage with the patient and their family, then you start to realize very quickly what those dynamics are. And once you figure out what those dynamics are, then you can engage the question of how would you like your care to be delivered today? Would you like it to be delivered in a collaborative and a family-based setting? Would you like us to include your family member who's here with you? Or if they're a friend, should the friend be involved in the decision making? But that's how you know how to take care of the patient from a cultural standpoint, instead of just what we know, what we're used to from our day-to-day.
So I have a question about like personal space, because we lived overseas for 6 years. And in some countries that we visited, like there is no personal space. Like people are like in your grill, as I like to say. and in some places people were super big touchers. And then in some cultures, it was very customary for people to stand very far apart and they weren't touchers and huggers and that kind of a thing. And it was respect. So I was wondering, are there those physical, comfort zone differences in the Asian culture as well? Like, not everybody wants to be hugged and patted on the back and, in that instance.
I've got a couple examples there. All three of us having a Texas root, there is no concept of space. We're all huggers.
Yeah.
We're all we all use special terms, of endearment with each other.
Bless your heart.
Well, that's native and natural to us. So that's a perfect example is, being from Texas, growing up in Texas, and then now living in California, those terms don't exist here in California.
They don't.
Agreed. Yeah.
In the same way, the Asian culture is the same way.
Mm-hmm.
Right? In Asian culture, there is no concept of space. As a Taiwanese American, I was born in Taiwan. I immigrated to the States when I was just over 1, but I still remember going back a lot to Taiwan, even after I immigrated here, what it was like to take the subway, to take the buses. And you realize very quickly that there is no concept of lines. You just get in one. And so it becomes a mosh pit. And no one knows who's paying next, but it's a mosh pit and you just get in the line and you just find your way to the front.
My OCD is cringing right now. Like, where's the order?
But it's so normal.
I would die. Yeah.
It's evidence that you're a foreigner though. When you're in those Asian countries and you're like, where's the line? And you're like, that thing over there is the line? You mean the big circle and group of people? In that standpoint, there is no concept of personal space.
I'm a surge tech. I need order.
There you go. Now, when it comes to the culture itself, when you see these patients in the clinical setting, there is a concept of space. You don't use terms of endearment because that's almost a little bit of a taboo. Growing up in Texas, I remember hearing, honey, oh, sweet baby darling.
Or sugar. I had that one.
Sugar.
Sugar.
Any of those terms of endearment, it's not used in the Asian culture. That's those nicknames, pet names, that's not really a thing we use. Also, because of that, there is really no, there is that change in personal space, meaning you're not going to go up to hug someone. You're not really going to provide any special signs that may be misinterpreted as affection, right? When you see these patients in pre-op, they know that they're like, oh, I don't care that you're a nurse. You're like the same as a doctor. You're going to take care of me. And they fully trust and believe in you. For scrub techs that have the opportunity, I've worked in a couple places where the scrub techs were able to come out and introduce themselves to the patients and say, I'm going to help the surgeon take care of you today, which was this very special moment, right? The patients never know who they're going to meet behind that red line. Mm-hmm. But when the scrub tech can come out and they can meet the patient doesn't care that they're a scrub tech. Heck, they don't even know what a scrub tech is.
Right, yeah. Nobody does. Yeah. Welcome to my world, right?
You're going to take care of me. And that patient, the Asian patients just so genuinely appreciate it. And they just feel so special. And knowing that there's that touch, they just feel so good about the kid that they're about to receive. And they believe and they trust you wholeheartedly because having a medical degree of any sort, a clinical degree, puts you up on a pedestal. And that pedestal means there's such a high level and degree of trust in your professionalism and the care that you're going to give. And so when you are taking those patients, they fully, wholeheartedly believe and trust in everything that you're going to do.
Okay, so I have another question. As you've talked about personal space and understanding the differences between our American culture and the Asian culture. Another thing that we get taught in school and get taught to really pay attention to is herbal remedies and different treatments that are not necessarily Western medicine. So how do we respectfully take that in and remember to even address it before we take a patient to surgery?
Absolutely. We talk about in pre-op, we might interview a patient, whether the pre-assessment nurse or the pre-op nurse may ask the patient if they use any illicit substances, if they use anything like smoking, any alcohol, right? But no one really asks about, do you use any home remedies, any herbal remedies? And of course, we know things like ginkgo, ginseng, those certain herbs that can potentiate the risk for bleeding as almost like a blood thinning agent. And we don't really think about those. As a pre-op nurse, as a pre-admission nurse, or as a circulator, you can ask patients, what does their typical diet consist of? If you have the time, the luxury of time to ask, where you may divulge some of that information from the patient. Knowing that some patients may use that is part of the culturally focused care of the patient. A great example is when I worked at my first ASC, very quickly, I transitioned to a physician liaison role because the month before I started there, a gastroenterologist who was Chinese speaking as well had an over 80% population of patients that were Chinese speaking only. And he would bring all of his patients to the ASC on Thursdays to do EGDs and colonoscopies. Well, very quickly, I realized that most of them didn't speak English. And we had a language phone, but we didn't have a tablet because it's an ASC. It's not a hospital owned. It's a physician owned ASC. So how do you provide that culturally competent care? Well, very quickly, when I was in pre-op and I was pre-oping these patients, realized very quickly that I actually speak their language. I understand them. I can talk to them. And in talking to them, realized that the questions that we're asking them in pre-assessment were not the same questions that we should be asking those patients, because we were asking the same questions to every patient. We were literally asking the same medical history, surgeries, medications. No one was talking about the pre and post-operative care, where very quickly I realized these patients were asking me, what should I eat after surgery? And this is where understanding of cultural backgrounds, cultural barriers plays a difference, because the Chinese patient population specifically, as well as some other Asian populations, they follow the model of the yin and the yang. So when your body is after surgery, there's certain foods that you shouldn't eat. You shouldn't eat cold stuff. Yet, let's think about it. When kids get tonsillectomies and adenoidectomies, what do we tell them to have after surgery?
Ice cream.
Cold stuff.
Ice cream, cold stuff.
Right.
But culturally, that's a taboo for the families that follow that mindset. And instead, because the body is in a cool state after surgery, or as at a warm state after surgery, then you should eat warm things. But wait, isn't that going to increase the risk for bleeding? But culturally, you're replenishing the body. And so having that understanding, the backgrounds and how much they affiliate or align themselves with the cultural biases or cultural differences really impacts how you provide the care. Because with those patients, I would start telling them, you know what, if you're going to do a herbal chicken soup after your colonoscopy EGD, go ahead and do it the night before when you're drinking your prep anyways. And that way, when you go home after surgery, you just heat it up and you're ready to go. Because it's the herbal stuff. There's certain herbs that we talk about from Eastern medicine that help to replenish, so to speak, your red blood cell count. It helps in your bone marrow. It's those things that having just some understanding of that patients may use that really can take your clinical care up to the next level.
So Charlie, I want to ask you, because, we can just, I don't want to get us to the point where we're just lumping people into just Asian population, right? That would be like lumping all people into Spanish speaking or Hispanic, because there are so many different areas. But, there are different categories and different, less broad, right? But there are more specific populations within the Asian community that we can narrow it down into, because there are major differences, right? Can you speak more to that?
So, if we look at the American healthcare system right now, if you want to look at the demographics, you see the Asian patients are the fastest growing patient population because a lot of them are immigrants, right? They're all coming here. They all want a chance at the American dream and to really own their futures, right? So they're leaving their countries to come here in hopes of a better life, right? Now, let's also be honest, the currency exchange can be a lot better, taking the American money back to their homes. So yeah, I can't fault them for it. That's how I like to travel when I go to Asia. I like taking my American money and spending it there. It goes so much further. But when we look at the most populated patient populations or Asian patient groups, you have the Chinese population, you've got the Filipinos, and then the Vietnamese. Those are our three biggest Asian patient groups. Now, what you'll notice about all three of them, which I think many of us can figure out, is that none of them speak the same language. They are all very different, and their cultural influences are very different, right? The Chinese culture, a lot of times when we look at the demographic numbers from the US Census Bureau, a lot of times they include my own group, which makes me so sad. They exclude the Taiwanese, but just Chinese alone, without the Taiwanese people, it's still the biggest Asian population group, regardless. Now, Chinese people do outnumber Filipinos by over 1 million. Now, language-wise, there's differences. We can already figure that out. Their cultural, societal influences are very different. Chinese have very strong ancestral roots, right? It's a big country. They have very, very strong roots. But let's also be honest. There's over 100 dialects. There's over 100 ethnic groups. And those ethnic groups regionally do not speak the same language. A great example for me is I'm Taiwanese. I'm one of the very few Taiwanese Americans I know who actually is fluent in Taiwanese. So Taiwanese is very similar to Hokkien. And Hokkien is spoken by some people groups in southern China, but is not a predominant language. So in China, they may not understand what I'm saying in my Taiwanese, even though the predominant language is Chinese.
Well, and then there are different religious backgrounds too.
Yes. So there's Buddhism, there's Taoism, there's ancestral worship. There might be some Catholics in there. There might be some Christianity. There's a lot of atheism. It varies among the Chinese group. Now, if we look at the Filipino group, predominantly we see them as having a very Catholic base, right? There's a lot of Catholicism there just because it was very much owned and colonized by the Spaniards, by the Europeans. So they've got that strong influence, which a lot of them have those names.
Well, I didn't know that. That's actually something I learned like last year. So it's almost embarrassing to think that I learned that last year, and I'm too old to have learned something new like that. I should have known this sooner. But seeing those names that were Hispanic, they seemed to me to be Spanish in nature. And then they were like, oh no, they're Filipino. And I'm like, but why?
Yes.
Oh, because of the Spanish influence and the colonization of the Philippines. And I'm like, I had no idea.
But if you think about it, in Spanish, uncle and aunt in Spanish is tío and tía.
Tío and
right?
tía. Mm-hmm.
But then in Tagalog, it is tita and tito, right? It's
right.
So close.
Yeah, it is very close.
So close.
Yeah.
And that explains why that is so close. Having some of those language affiliations, because there was the period where they were colonized. Now, like if you look at Vietnamese, the Vietnamese has a very strong French influence because France had occupied them for a while too. So just look at these three people groups among the Asian subset. It's crazy to see just how different they are culturally. And because of that, the culture aspect of who may have occupied or colonized them during those periods, there have religious differences too. And religion itself, politics can be such a part of a country's culture and religion. We don't necessarily think about that. We're seeing it somewhat nowadays, but in some of these Asian countries, the politics almost becomes like a religion for them because they ascribe so heavily to it.
Yeah. Well, and there's so many things to keep in mind and so few minutes to consider all of these items in the little interaction that you have with that patient before they're anesthetized and put on our table and cared for. It's a lot to consider.
Yeah. And like an easy way to consider it is, like as part of your 5-second best friend regimen is to potentially ask, what is your cultural identity? Which culture or background do you ascribe to the most? And how might that impact your care today? And really open-ending that question for the patient to have them answer it, because that can really make the patient experience astronomically better.
Yeah, and opening yourself up to listening to them and, letting them dictate how we're going to, adapt to caring for them within the reasons and limits that we can. But these interviews go too fast. I'm going to advocate for more time eventually. But anyway, that is a great start to advocating and for better care for the patients we have who are in our Asian populations. But are there other things, as we are tying this conversation up, how else can we make surgical care better for our Asian patients?
Yeah, so language assistance is always something that we can always consider, right? A lot of our big hospitals, we've got in-person or video interpreters, and so that makes a huge difference. Us ourselves, I know a lot of nurses that use Duolingo and other language learning platforms to really help learn a little bit more to be able to start to create that connection with the patient. Now, does learning these other languages necessarily mean that you're culturally competent? By no means, right? But it's a way to create a connection, but just language is not sufficient to really call yourself culturally competent. But having that connection, being open-minded, these Asian patients will recognize that depending who their nurse is, who their tech is, they're going to act in a way that is natural for them. And so they won't fault you for smiling at them. They won't fault you for making eye contact with them. They will respond in the way that they respond, but they will respect that you will respond to them in the way that you are used to. So language assistance is always helpful, but always give the patient the opportunity to declare whether or not they would like it. Even though we should always offer it in the workplace, some patients find it very much that they lose face. In the Chinese culture, we have this phrasing called "you lose face." It's a sense of our pride. And if you think your English is so good, but all of a sudden my nurse brings in the interpreter tablet, it could make it better, but it could also make me lose my face because it's not good enough, right? We want to do what's right by the patient, but we also want the patient to drive that decision, right? So if the patient says, no, I'm going to do this, that's fine. Then use plain language to communicate with the patient. You don't have to use the big words. I do that in my practice. I have a lot of Chinese-speaking patients in my practice in California, and I understand the language, I understand the culture, and I give the patients and families the authority to tell me if they want me to use an interpreter. And as I start communicating, even the patients that don't want an interpreter, I ask them, I do speak Chinese. I'm happy to communicate in Chinese if that is what you would like.
Yeah. And don't make that assumption for them. Yeah,
correct,
for sure.
Correct. Because you just don't know where they're going to fit into the picture, but you're giving the patient the ownership of their clinical care for that reason. So
such great
interpreters are great. How do you engage the family? Again, asking the patient, who do you want to be involved in your care today? Who do you want to be part of your clinical decision-making team today? That makes a huge difference because, again, that gives you hints and glimpses into their cultural affiliation. Are they more so Americanized? Are they truly ascribed to their cultural roots? That will help to give you little hints and tricks without you even having to ask those questions. And that makes you a better clinician by knowing some of those tips. Some of the cultural sensitivity differences, again, when I go to Cambodia to do surgical missions, I have to remind myself every time, those patients, you cannot tell them to hug their family, to hug their children as we take them to surgery. That is a huge no-no. So for those patients, I have to remember when I'm in Mexico doing missions, I tell those families, would you like to give your child a hug or a kiss before we go? And a lot of times they will bless them before we go. And it's really endearing. But in Cambodia, I have to hold my tongue and bite my tongue and say, oh, don't do what I normally do.
Yeah. And is it because they see that as taboo? They see it as bad luck?
Because of that affection.
Got it.
Yes.
Yeah. Okay.
You don't do that.
Oh my goodness.
Just don't.
That is
and
interesting.
as a nurse who does missions, you would think we would know better.
Right. But we also have our own
American
habits.
level care to someone who's truly in need of services that they may not be able to get otherwise. But oh my gosh, I don't want to create a weird situation, bring my American ideals into your culture.
Well, that is actually probably a great way to wrap up this conversation. Remembering not to bring our American ideals into assumptions about the culture of the patient in front of us, and learning and respecting the culture of them, and so that we can make them feel comfortable when they are in our space and we are taking care of them. So, Charlie, we've come to the end of this conversation, but is there anything else? I know it's way too fast. Anything else you want to leave us with before we go?
I think when it comes to the care of the Asian patient, again, is to give the authority to the patients and their families. We always give authority decision-making to patients, but a lot of times we forget about how we engage the families. And depending on how closely they ascribe to their cultural roots, that may be just as important as including the patient. So we really should consider that. And we should consider that the Asian patient may not necessarily be the most verbal patient. It can be anxiety. It could be how they want to manage their pain. It could be, again, back to language utilization. They appreciate the care so much and they trust the specialists for the care that we provide, but they just may not be the most vocal. And we have to use our nursing judgment to figure out how best to help take care of them, and whether or not do we medicate, how do we act? How do we include their cultural practices in their post-operative experience and preoperative experience?
Great advice. Thank you so much for everything that you've taught us. And if this is the first time he's been on, it's not going to be the last.
No, it will not be the last. He's in our clutches. He will come back. But Charlie, thank you so much. I really appreciate you being here today.
Thank you so much for this opportunity. It's great to be able to speak on such a topic that's so rarely discussed.
That was Charlie Lynn, nurse practitioner and first assist at Stanford Children's Pediatric Otolaryngology. And Chris, Charlie really did a good job today opening our eyes to the differences that we will see in our patients from Asian cultures, and helping us realize it's not just language that's different. Culture is different. Religion's different. And within the Asian population, there's so many differences even within those patients. So I think he really helped us get a better understanding of grasping everything that we might be dealing with when we have an Asian patient in our operating room.
Agreed. And I think that just taking those few minutes to pause when you do realize that you're going to be able to interact with the patient within that culture and those varying populations, and taking into consideration all of that will just help ease the patient, will help you take care of the patient better. And I mean, that was just the tip of the iceberg. I can't wait to talk to Charlie again.
I know. And like I said before, we're recording this before the AORN Expo, and I will be planted in his presentation to hear more about it and learn from him at Expo.
The audience is going to be so lucky to
they
hear
will definitely benefit from him for sure. That's all the time we have for today. Tune in next week. We are bringing JD Boucher back into the studio, and we're going to be talking about caring for our transgender patient population. It's going to be a wonderful conversation. You don't want to miss it. On behalf of Chris, myself, and everyone here at First Case, thanks for listening to this week's interview.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.